Regarding the conduction system of the heart, as you know that the impulse is generated in the sinoatrial node, and from the sinoatrial node the impulse propagates through the atrial bundles and they collect together in the atrioventricular node, where there a delay happens and occurs in order for the atria to contract before the ventricles, and then it traverses through the His bundle. This is the His bundle that divides into two major branches, which are the right bundle branch and the left bundle branch. And the left bundle branch also gives two important branches, which are the left anterior fascicle and the left posterior fascicle. Very important for you to know that the blood supply of the SA node, it comes mostly from the right coronary, as well as the AV node. It's almost 90% of cases they are supplied from the right coronary arteries, as well as the His bundle. So the SA node, the AV node, and the His, they are mostly supplied from the right coronary artery, other than the left and the right branches, which are supplied from the left anterior descending artery, and they may receive collaterals from the right coronary arteries. This is the structure of the AV node, and in this structure here what happens that the grades of AV block occur. When we say about first degree, second degree, or third degree heart or AV block, this where the site it occurs at the level of the AV node or the His bundle. This is the structure, as we said, that the impulse collects from the atrium, it enters the atrioventricular node that has two pathway, the fast pathway and the slow pathway, and then gives the His bundle. What is first degree AV block? What's the definition? The definition of the first degree AV block, it is a constant prolongation of the PR interval. So you can notice here that the PR interval from here to here is constant from the beginning to the of the P wave, okay, to the Q wave. This is the PR interval, so it is constant. Wherever you go through the ECG, it is a constant PR interval, but it is more than 200 milliseconds. So each one in here, you can notice that it is more than 5 small squares. 5 small squares, which is equal to 1 large square. Okay, this is 1 large square. So it is more than 1 large square, more than 5 small squares, and this is the definition of the first degree AV block. Don't forget, constant interval more than 200 millisecond, and this is very common to occur in elderly patients. Regarding the second degree AV block, it is further subclassified into two types, which are the Mobitz 1, also called the Wenckebach, and the Mobitz 2. And how should we differentiate between the Mobitz 1 and Mobitz 2 and even first degree AV block? In Mobitz 1, you should notice that there is a progressive prolongation of the PR interval. You can notice here that it is almost 5 squared. This is more than 5. This is almost 2 large squares, and there is a block. There is a non-conducting P wave that occurred here. So there is a progressive prolongation till a non-conducting P wave, followed by this isoelectric line. You can see this line. Progressive prolongation, more prolongation, non-conducting P wave, followed by an isoelectric line. Very important clue in the exam or question that you will be asked. It is very common to be associated with inferior myocardial infarction. So Mobitz 1, it is associated with inferior myocardial infarction. Regarding Mobitz 2, Mobitz 2 is a little bit different, but also remember that it is associated with anterior myocardial infarction. Mobitz 2, they are more common to occur with anterior rather than inferior. Mobitz 1 inferior, Mobitz 2 with anterior myocardial infarction. How should we differentiate and define it? The PR interval is constant. It's always constant, but there is one intermittent non-conducting P wave here. So the PR interval is constant throughout the ECG, but there are non-conducting, intermittent non-conducting P waves that occur on the ECG. You should think of Mobitz 2 if you see this ECG in patient who has history of anterior myocardial infarction. What about third degree AV block? This is also called the complete heart block. What you should know about this? Very important notes that you will define and see them on the ECG in order to diagnose the ECG, and also those clues you may be asked in them, each one of them in the MCQ questions. What are those? The first one, there is complete dissociation of the P wave and the QRS complexes. The second is that the PP interval and the RR interval, which we'll discuss now, are constant. Those intervals are constant, while the PR interval varies. So let's go to the ECG. You can see here, let's look at lead 2. You can see here that the let's look at the QRX complexes. The QRX complexes, they are constant. 1, 2, 3, 4, 5, 6.5. Between each QRS complex, they are constant. So the RR interval is constant. 6.5. If you want, count 1, 2, 3, 4, 5, 6.5, and this is 6.5. Large square. So the RR interval is constant. Let's look at the PP. The PP waves, the PP intervals, they are also constant. So the RR interval and PP interval, they are constant. But what varies here is the PR interval. You can notice here that this is the PR interval. See, the PR interval is long, the PR interval is shorter is very short, and here the P wave is embedded within the QRS complex. So the RR interval is constant, the PP interval is constant, while the PR interval varies. Okay, so and there is complete dissociation between the P waves and the R waves. What does that mean? That means that the P waves, they depolarize in a matter that is different from the ventricular depolarization. Each has its own depolarization and works separately. So here is the QRS complex, and there are P wave here. So there is complete dissociation between the P waves and the QRS complexes. So please do not forget those points, that there is complete dissociation between the P waves and the QRS. The PPU interval and the RR interval, they are constant, while the PR interval varies. Okay, and also you must know that the P wave, the atrial rate is faster than the ventricular rate. So you can see in this block that there are more P waves which are 1, 2, 3, 4, then there are 2 QRS complexes. So the atrial rate is faster than the ventricular rate, or the ventricular rate is slower than the atrial rate. There are 2 conditions that you should be aware, that it can be congenital, or it can be an acquired causes for complete heart block. Congenital causes, usually they arise in siblings, kids of mothers who have autoimmune connective tissue disorders like the systemic lupus erythematosus, and the escape rhythm in those congenital conditions of complete heart block is usually well tolerated. So the child can live, he has no symptoms, he is well tolerating his complete heart block even into adulthood, as the escape rhythm is usually more than 50 beats per minute. While in acquired complete AV block, usually it occurs in elderlies. In the elderlies, and the escape rhythm is usually more than 40, and the patients are symptomatic, they cannot, it's not well tolerated, and they need pacemaker implantation. 6. Sinus dysfunction. What is 6 sinus node dysfunction or 6 sinus syndrome? There are 4 entities that you should be aware of, which are called the inappropriate sinus bradycardia, which is also called the chronotropic incompetence, so it's the same. The sinoatrial exit block, sinus arrest, and the tachybrady syndrome. The inappropriate sinus bradycardia or the chronotropic incompetence, it is simply defined as it is a sinus bradycardia, less than 60 of course, but it does not increase with exercise. And this is, sometimes it's common to be seen in elderly patients who are having dyspnea on exertion. Why they do have this dyspnea on exertion and everything else is fine with them, you can find that they are having an element of bradycardia, and it does not increase the heart rate during exercise, so the cardiac output does not increase, so he cannot maintain this blood flow and nutrients to the muscles, and he gets this dyspnea and exertion and fatigue. This is the chronotropic incompetence. While the sinoatrial exit block, I want you to concentrate with me, please. Sinoatrial, it is an exit block. What does mean an exit block? It means that there is an impulse that is generated in the sinoatrial node. We are talking about sinoatrial node diseases now that affects the sinus node dysfunction, inappropriate sinus bradycardia, sinus atrial exit block, sinus pause, sinus arrest, tachybrady syndrome. They are all diseases of the sinoatrial node, which is different than the AV block that we talked about. The impulse in exit block is generated. It has actually generated inside the SA node, but it cannot leave the node. And this results in a pause. This is important. This results in a pause. But what's the characteristic of that pause is that it has the multiple of the PP interval. Please, I want you to understand this. This is the P wave, this is the P wave, and this is the QRS, and this is the QRS. And here is a QRS. The other QRS, it should be exactly here, and the P wave, it should be exactly here. So when it is the exact number, the pause is the exact number of the PP interval exactly, or the RR interval, this is called an exit block. This is called an exit block. You can understand that there is impulse. It has been generated, but it did not leave the SA node, resulting in a pause that is the exact number of the PP interval, which is different than the sinus pause. In sinus pause and sinus arrest, the SA node fails to generate this impulse, so it fails to depolarize. Both of them, they fail to depolarize, and they result in a pause. So sinus exit block, this exit block, the sinus pause, and the sinus arrest, they all result in pauses. But the characteristic of that pause is the clue for you to answer your ECG or to answer your MCQ question. If it is the exact number of the PP interval, then this is an exit block. If it is not the exact multiple of the PP interval, which is plus minus 2 small squares, so this is a sinus pause. And if it is, the pause is less than 3 seconds, this is a sinus pause. This is a pause. If it is more than 3 seconds, this is an arrest. So if it is less than 3 seconds, it's either exit block, or pause. Suppose if it is more than 3 seconds, then this is an arrest. This is what you need to know. Usually sinus pause, it can occur in athletes and it has no clinical outcome, but sinus arrest, this is a very dangerous, and it is always followed by an escape rhythm, which is different than the sinus pause. Let's talk about it on a real ECG. This is a real ECG. I said that there is a QRS complex and there is a pause. What defines this ECG? This ECG is characterized by the complete absence of atrial contractions, no P waves. There are no P waves from here to here. There are no P waves. So what happens? What's this? This is an escape rhythm. This is an escape rhythm. So no P waves. This is an escape rhythm. In sinus pause, there is an escape rhythm, like this one. This is sinus pause. If we say, is this pause or this is exit block? If we calculate this P to P, it will be not the exact PP interval with minus and plus 2 small squares. So this is a sinus pause rather than it is a block. If it is the exact, then it is a sinus. If it is a sinus exit block, if it is the exact PP interval. But as long as it is not the exact PP interval, this is a pause. Is this a pause or this is an arrest? First of all, it is less than 3 seconds. As long as it is less than 3 seconds, as we said, so this is a pause. And the second thing, there is no escape rhythm. This is sinus, P wave, and then the QRS sinus, and then QRS, and then comes back sinus and QRS, which is different than this ECG, which has no P waves, and this is an escape rhythm, and this is more than a 3 second long. This is the difference between sinus pause, sinus arrest, and the exit block. And this is the tachybrady syndrome.